Dr. Jane Kelly, Assistant State Epidemiologist for the South Carolina Department of Health and Environmental Control. I've heard Dr. Kelly present a couple of times now along the way of this past year of the pandemic, and always am really just incredibly informed through her presentation, which is done with so much, with an ability to connect, to help this complicated information in a very approachable and accessible way. And also so generous of her time. And I'm grateful for the way, Dr. Kelly, that you have just been tirelessly going all over. Zoom helps facilitate some of that going all over. But just thank you for coming to so many different groups to speak and spread this information, this important information. And we, as a note to the group, we are going to record this part of the presentation. So if you don't want to be on screen, now's the time to change that. But we are going to be recording this, and then we'll have an opportunity. If you have questions, comments, please begin to send those in the chat box. Gia will help facilitate that after Dr. Kelly's presentation. And then if we come to a point where we need to keep going with our agenda, we will do that. I'll transition us back to our presentation. And Dr. Kelly is gracious and excellent at continuing to respond in the chat box to other questions that might come along the way. So with that, thank you again, Dr. Kelly, for joining us. And I'm going to stop sharing my screen so that you can share yours, and welcome.
Great. Well, thank you for that kind introduction, and thank you for inviting me, because at this point, word of mouth communication is so important. I've included a number of slides in the presentation I'm about to give about vaccine hesitancy. And the more I learn about vaccine hesitancy, the more I realize our messages of just facts go just so far. It is hearing from people's personal experiences, talking to others who have gotten vaccinated to find out, why did you get vaccinated? What was your experience? That's what I think is convincing many more people to go get vaccinated, rather than, oh, hi, I'm from the government, trust me, it's safe and effective. That just is not a very efficient message. So let me just see if I can adjust my slides. Hang on just a second. Oops, that's not the one I want. Okay. I want to start with a little bit of good news, and we'll end with good news. So here's the good news, that downward slope. So this is South Carolina. If you follow the green line, that's probably the best one, because it's a 7-day moving average rather than looking at day by day changes in the number of people diagnosed. So it is, we have been in a down slope for more than 8 weeks of new cases. And similarly, that is true in every region, including the upstate. All 4 regions are on a down slope, and the number of deaths is greatly decreasing. I don't have the numbers here for the proportion of deaths in nursing homes, but that has certainly plummeted. That was where we were seeing the most fatality. And now that we have a program where we have vaccinated a large proportion of the people living in assisted living or skilled nursing facilities, our number of deaths is greatly decreasing. However, we still are seeing new cases, and we are still seeing some spread of the new variants. So I have a very cautiously optimistic, positive message here, but I still want to emphasize how important it is. We've come this far. We need to maintain the gains. We still need to keep up our guard around wearing masks, keeping distancing, et cetera. But there's good news on the way, especially with vaccines. So let me talk a little bit about terminology, because I think sometimes these words are used interchangeably, but they mean a little bit different things. Coronaviruses, it has that name because corona in Latin means crown-like. The coronaviruses are a group. They are a family of viruses. Some of them even just cause the common cold. SARS-CoV-2, that's the virus that causes the disease COVID-19. And I'm going to go into a little bit of biology here, because I think it's important in understanding how the vaccines work. That cartoon on the right-hand side is what the SARS-CoV-2 virus looks like under the microscope. It has a coiled loop of what's called RNA. That's the genetic code for the virus. We as humans, we have DNA. What this virus has is a related molecule called RNA. And surrounding those genes are a protein lipid coat, which includes something called the spike protein. The reason that's important is because that spike protein is almost like a key and a lock to open the door. The spike protein is what attaches to the cell and basically opens the cell membrane so that it injects the virus RNA into the cell. And those are the genes or instructions to make more virus. I think you already know the symptoms of COVID-19. Some people are asymptomatic. Many people have just mild to moderate symptoms of cough, fever, chills, muscle pain. Some people go on to get shortness of breath or difficulty breathing. And sometimes it can really look a lot like influenza. The sore throat can mimic the sore throat you get with strep throat. So it's important if you have any of these symptoms to get checked to find out, is this just a cold or just allergies or strep throat, or is this COVID-19? One symptom that's really peculiar to this is a new loss of taste or smell. If that is experienced, that really is a red flag for getting tested. Unfortunately, some people experience what's called widespread vasculitis. They get disease in many organ systems. Any word that ends in itis means inflammation of, like conjunctivitis or dermatitis, arthritis. They all mean an inflammation of that organ system, that part of your body. Well, if you have inflammation of your vascular system, that's inflammation of your blood vessels. So that can affect basically any organ of your body. You can get pneumonia, but also with COVID-19, you can get heart disease, kidney disease. It can affect your liver, your intestines, your brain, and unfortunately, it has a severe effect on women when pregnant, and it is possible for the virus to pass from mother to child. So that is why vaccine is so important for decreasing mortality and decreasing the severity of disease, because even people who have severe disease and survive, they may end up having some permanent damage to some of those organ systems. I like this little cartoon because I think it gives a picture of how vaccines work. Vaccines provide a sneak preview. So in this cartoon, there's a wanted poster on the wall. It shows what the virus, the SARS-CoV-2 virus looks like. And those angry looking white blood cells, those are the ones that make antibody to fight virus and bacteria infections. And they're looking at the two SARS-CoV-2 viruses that have just entered, and they're angry because they recognize them right away. They don't have to wait to learn that this is a foreign invader and make antibodies. They've already seen it. They've already made antibodies and other immune system responses. Many people have asked, how is it possible to create a vaccine in such record time? I thought it took years to make a vaccine. I'm not sure I trust a vaccine that was created in less than a year. How can you be sure that it's safe and effective? I think there's a little bit of a misunderstanding about how rapidly these vaccines were created. If you look at the full stages of developing a vaccine, the longest step is the basic science research. That's the research that usually takes years. As soon as they've done the basic science research, doing the animal studies, testing it in rodents or in monkeys, doesn't necessarily take a long time. It could be as short as a month. And then they move into doing studies in humans, those phase 1, 2, 3 studies in humans. And I'm going to talk about those as well. But to think about that basic science research, when did that begin? Well, it actually began in 2003. Do you remember SARS-CoV-1, the original one? The severe acute respiratory syndrome, it broke out in China. It did become a pandemic, about 8,000 cases around the world. We had cases in the United States. And they started work on a vaccine right then and there in 2003. Fortunately, SARS-CoV-1 is not as contagious as SARS-CoV-2, so it was contained. The outbreak stopped. And so the vaccine companies stopped working on making a vaccine, but the basic science research continued. Research done at academic institutions, at NIH, the National Institutes of Health, at the World Health Organizations, at multiple agencies around the world. So we've actually got 17 years of basic science research. So when SARS-CoV-2 appeared on the scene in January, they already had a lot of information on SARS-CoV-1, and the two viruses are very closely related genetically. So the information they had from SARS-CoV-1, they could apply to SARS-CoV-2 vaccine. They quickly got vaccine into animals as early as February of 2020 and into human studies as early as March of 2020. Now, let's talk a little bit about these human studies. What do they do when they do these phase 1, 2, and 3 trials? Phase 1, they test a vaccine that's already been proven to be safe in animals, but they test it in a small number, maybe 100 people, young, healthy people with no medical problems, just to make sure there are no safety concerns, and they look to see if there's an immune response. If that looks good, they go on to phase 2. In phase 2 studies, they have a greater number of people, maybe up to 500 people. But now they're also looking to figure out, is this going to be a single dose vaccine? Do we need 2 doses? And how far apart if we need 2 doses? So it's a little bit more complicated. Phase 3 studies are the ones where they have literally tens of thousands of people involved. Now, this is the other piece that was really different with SARS-CoV-2 vaccine development. Usually, vaccine companies do those phase 3 trials over a couple of years. They do it that way because human studies are expensive. You have to pay people's transportation to come in to get vaccine and be tested. You have to provide them some sort of a reimbursement for their time, an incentive. You have to do all the blood work. You have to hire physicians to do examinations. So normally, vaccine companies do this in baby steps. Phase 3, they'll have maybe 300 people, do the tests in them, and then if it looks good, they'll go on and recruit another 300 people. And if that looks okay, then they'll go ahead and do another 300 people. They do that because they want to make sure they've got a sure thing before they invest a lot of money. What was different in 2000 was that the US government and other governments around the world, as well as certain philanthropic groups, they offered money and said, don't wait, go ahead and recruit tens of thousands of people. We will invest in you recruiting tens of thousands of people right away into your vaccine trial. So for example, Pfizer and Moderna, which are 2 of the vaccines that are available in the United States right now, they each did phase 3 studies beginning in June, and they were each able to get over 30,000 people involved in just 2 months. That's something that normally would take them a couple of years, but there was that degree of urgency. So there was funding, there was a business case why this vaccine was different. No steps were skipped in developing these vaccines. It's just that they were overlapping. And in this case, with the phase 3 study, it was that they were able to recruit a great number of people all at once. I'm only going to show this slide for the Pfizer vaccine, but the same story is true for Moderna and the Janssen vaccines. Those are the 2 other vaccines that are available in the United States. They all did studies in multiple places, not just in the United States, but in other countries as well. And they made certain that they recruited people of different race and ethnicities. So if you look all the way on the right-hand side, it says participants in the overall study and the US only. They recruited Black and African Americans. They recruited Hispanic Latinos because they did a number of studies in Latin America, with 26% of people involved in the Pfizer vaccine phase 3 studies were of Hispanic Latino descent. And they also made sure to test it in the very old, up to people age 85 in Pfizer vaccine, and down to age 16 in Pfizer vaccine. And lastly, they also tested it in people who had multiple medical conditions. Not just phase 1 was young, healthy people. Phase 3, they enrolled people who had diabetes, heart disease, liver disease, people living with HIV, because they wanted to make sure vaccines worked in them and were safe in them, and they were. Both Pfizer and Moderna vaccines were 95% effective, and they're quite similar vaccines. Remember I mentioned the spike protein? What they did is very clever. They did not use whole virus. There's no SARS-CoV-2 whole virus in their vaccines. You cannot get COVID-19 from these vaccines. What they did was they took just the gene, just the genetic code for the spike protein, put it into a vaccine, inject it, your immune cells respond, you make antibodies to just that spike protein. And remember, the spike is the key that goes in the lock to get into the cell. So if you've got antibodies to that spike protein, the virus cannot get into your cells. So that's how it stimulates an immune response. What are the other ingredients in those Pfizer and Moderna vaccine? I mentioned there was that RNA. It's called messenger RNA because it carries the message of how to make that spike protein. But the other ingredients are pretty basic: salts, sugars, some other lipids or fats, oils, and that's all to just coat the messenger RNA so it doesn't get broken down by enzymes in your muscles before it has a chance to be picked up by your immune system. It does have one ingredient that probably is the cause of some allergic reactions, and that's something called polyethylene glycol. It's a fat, it's an oil, and in fact, it's found in many common over-the-counter laxatives, but some people are allergic to it. Neither of these vaccines have any antibiotics. There's no sulfa, there's no preservatives, there's no mercury or aluminum, there's no egg, latex, all the things that sometimes people are concerned that they are allergic to. Is it in this vaccine? They tried very hard to make these vaccines as simple and straightforward so that to relieve those concerns about ingredients in the vaccine. I mentioned that both Pfizer and Moderna have extraordinary protection. So 2 weeks after the second dose, you have 95% protection from symptomatic COVID-19. That's really extraordinary. There are very few vaccines that can offer that sort of protection. The new shingles vaccine, measles vaccine, but most vaccines aren't as effective as that. That's really incredible. For Pfizer, you get 1 dose and then 3 weeks later, you get your second dose. For Moderna, you get your first dose and 4 weeks later, you get your second dose. And you really want to stick with the same one. You don't want to mix and match these 2 doses. So for each of us, we have to make a decision about what are the benefits and the risks. Do I want to get vaccinated? Each of us has to make our own assessment. So in terms of benefit, well, I did just say that these vaccines are 95% effective, and that is really high. What about risks? I'm going to talk about 3 types of risks. One is the after-shot symptoms, because many people have some symptoms after they get vaccinated. They're temporary, but we should talk about them. There's also the possibility of an allergic reaction. And then there are always the possibility of a rare event. Some people have no symptoms at all or very mild one, but many people report mild to moderate side effects after receiving, especially the second dose of vaccine, of feeling tired, pain or swelling at the site where you got your shot, fever, chills, or headache. These are temporary though. They last for 1 or 2 days. What about severe allergic reactions? Thus far, over 100 billion doses of the Pfizer and Moderna vaccine have been given in the United States. And what they have found is about 3 to 5 people per million doses of vaccine have had severe allergic reactions. Now, I don't mean just a rash or soreness. I mean having shortness of breath, difficulty breathing, maybe wheezing. That is a little bit higher than the severe allergic reaction rate that we see for influenza vaccine, which is about 1 in 1 million doses. But it's not a surprise. Vaccines, sometimes people are allergic, just like sometimes people are allergic to penicillin or to different foods. And it's a treatable condition. If you are a person who has allergies in general, and again, I don't mean hay fever, I mean a severe allergic reaction to peanuts or shellfish or seafood, or allergic reaction to other medications, when you go to get your vaccine, just let them know. Because what they will do is they will ask you to just sit and wait for 30 minutes so they can observe you and make sure that you're feeling okay before you leave. What about rare events? So I need to update this slide because this number has changed. We now have had over 100 million doses of these vaccines given in the United States. So it is possible that we will see some more rare events as millions more and more people are vaccinated, but so far so good. We really are not seeing any unusual rare events. There are always cases that get reported in the news, and CDC investigates them. You know, was something, you know, someone had their platelet count dropped. Is that related to the vaccine, or was it just a coincidence that that happened 5 days after their vaccine? I think that thus far we have very good information to support that safety is high for both of these vaccines. Now, I want to mention the third vaccine. This is the one that was just recently approved. This is the Janssen vaccine. It's also known as the Johnson & Johnson vaccine. Johnson & Johnson is the parent company. It's a big company, makes lots of different products. Janssen is the part of the company that specifically makes vaccine. So I'm going to give you a little bit of detail for those who might want to know this. The way this vaccine works is they take an adenovirus, that's the common cold virus, but they weaken it so that you can't get the common cold from it. And they put in, again, the genetic code for the spike protein, but they use a little bit different molecule. They use DNA. And the reason they do that is it's not as fragile as RNA. And the reason that's important is it means they can just keep that vaccine in the refrigerator. It doesn't have to be frozen, doesn't need, special super cold freezers, and it can sit in the refrigerator and it's stable for months. The other important thing about this is that it's a single dose, one dose, and you will get high protection. It's a technology that has been used for lots of other vaccines, Ebola, Zika, something called respiratory syncytial virus. And most people have only mild symptoms after vaccination. So it seems to be easier on you than the Pfizer and Moderna vaccines. It was approved the end of February. We started receiving doses in South Carolina in March. What are the common ingredients in Janssen? It has that gene for the spike protein. It has that weakened cold virus. Oh, and I'm sorry, the reason those images, it's like the cold virus acts like a delivery truck that is bringing that DNA to a person. The other analogy I use sometimes is the Trojan horse. That's the story that the Greeks were at war with the Trojans, and they gave them a big wooden horse, but the Greeks hid inside it. The Trojans thought, oh, this is a gift that they're surrendering in the war, and they brought it into their fortress. And then in the middle of the night, the Greeks jumped out and were able to fight off the Trojans. The same idea here. The virus, the weakened cold virus, is the horse that's bringing in that spike protein DNA. So what else is in it? Same deal, salts, sugars, other lipids, no antibiotics, egg, but also no polyethylene glycol. Remember, that's the one that I said in the Pfizer and Moderna vaccines can give you an allergic reaction. This one has no polyethylene glycol. It does have polysorbate 80. That's another common ingredient. It's used in ice cream, it's used in salad dressing, it's used in a lot of over-the-counter products. But some people, if they're allergic to it, need to know that. When you go to get your vaccine, if they're giving Janssen vaccine, they will ask, are you allergic to polysorbate 80? How does it work? How much protection does it give you? The way they studied this was much later than the Pfizer and Moderna ones. So I want you to keep this in mind. Don't compare them side by side, because they studied the Janssen vaccine when we had all these variants circulating. So after one dose, 28 days later, it was 72% effective in preventing moderate to severe disease in the United States, 66% in Latin America, 57% in South Africa. Now that may sound concerning. That may sound like, oh, that's not a good vaccine. I want to remind you, they studied it at a time when there were those variants circulating. And the most important thing is prevention of hospitalization and death. So if we looked at that and said, oh, 72% versus 95%, why would I want the Johnson & Johnson? You can't compare. Pfizer and Moderna studies, probably if we did them today, they wouldn't be 95% effective in those different parts of the world. The important thing is to know that the Johnson & Johnson vaccine is 85% prevention of severe disease, and that's after just one dose. And there were 0 hospitalizations and 0 deaths in the vaccine group, including in South Africa, where 96% of the virus that's circulating is that South African variant. So again, this vaccine, Janssen or Johnson & Johnson, 85% effective against moderate to severe disease, 4 weeks after the first dose, 0 hospitalizations, 0 deaths. So this is an excellent vaccine. So let's move a little bit into talking about phase 1B and talking about vaccine hesitancy. So when can I get vaccinated? This was a poster that had been made for 1A when people could be 65 or older, but now we are in phase 1B. And if you are 55 or older, it is your turn to get vaccinated. The reason we go by the age number is if you look at mortality, it is very much linked to age. 80% of people who have mild symptoms that, they last 2 weeks and it's no big deal. But the majority of deaths that we have had in South Carolina are among older adults. Almost 90% of the deaths were among people aged 60 and older. But still, even 55 to 59, that bar still is showing a substantial number of deaths. So we're trying hard to vaccinate people who are older adults, as well as individuals with some medical conditions. So let's talk about who else is in phase 1B besides age. This can be found on our DHEC website, and I've included the URL, the website address. Individuals age 55 and up, but also people age 16 and older who have any of these medical conditions: cancer, kidney disease, lung disease, diabetes, Down syndrome, heart disease, HIV, organ transplant, like a kidney or heart transplant, obesity, but also pregnancy and sickle cell disease. And I'll return to talking about pregnancy. It also includes frontline workers, people who are in person, not teleworking, in person at their place of work, and perform a job in which they are at increased risk of exposure to other people because of frequent, close, and ongoing contact. That's a lot of people. There are some other individuals who are in phase 1B as well. People who work in group home settings, workers and residents in homeless shelters, community training homes, correctional facilities, immigration detention facilities, and migrant farm workers. We're organizing mass vaccination programs to try and bring vaccine to individuals at their work site to make sure people who may not have reliable transportation or have difficulty just navigating the system to get in there and make an appointment for their vaccine. We're organizing programs where we can bring vaccine to people. I mentioned those circulating variants. Let's talk a little bit about those as well. B117, that's the British variant, and it is in South Carolina and probably is everywhere in the United States, even though this map shows some states where it hasn't been discovered yet. B1351 is the South African variant, and it too is in South Carolina. The deal with these new variants is that they spread more easily. They're more contagious. It's not necessarily that they're more lethal, that they cause more severe disease. It's just that they spread more easily, and that's a problem. Will vaccines still work against these variants? Yes, definitely for the British, a little bit less for the South African. People may still get, after they're vaccinated, breakthrough infections, but they will not be severe. They'll be mild illness if someone is fully vaccinated. Let's discuss vaccine hesitancy. It's a continuum. There is a wide diversity of reasons why people might be cautious about receiving a vaccine or doubtful about receiving a vaccine. Some people are anti-vaxxers. They're going to refuse all vaccines, and that's that. And then there are other people who are clamoring from day one. They wanted to get vaccinated as soon as possible. I think most people fall somewhere in the middle where they feel like, I want to be vaccinated, but I want to wait and see. I'm not sure. I don't want to go first, and have many different reasons. This figure is from the Kaiser Family Foundation. They have been doing monthly surveys to look at vaccine hesitancy. So this figure shows that what people reported in answer to the question, if a COVID-19 vaccine was determined to be safe and available for free, would you definitely probably get it or definitely probably not get it? They did this survey in August and September, and then they repeated it in November, early December. And for every group, for Blacks, Hispanic, Latinos, and for whites, for each group, the number of people who said that they definitely probably would get it increased, which is good news. But they've been doing this, they did this survey again in January and in February. So I'm going to show you some other types of information, some updates. So this is a little bit concerning. This is from the February survey. 1/3 of young adults and Black adults, 1/4 of Hispanic adults said they want to wait and see before getting vaccinated. Now that was in mid-February. In mid-February, we had about 50 million people vaccinated who had at least received one dose of vaccine. And yet people were saying, they still want to wait and see how it is working for other people. Some of the other groups on here that I note is that adults without a college degree were more likely to say that they would wait and see than college graduates. And for those aged 65 and older, only 10% of people were saying they were going to wait and see. They'd already gotten the message that they were at risk and they wanted vaccination. This is also back from that December poll. And so this has changed, but I think it's interesting to look at this and look at the reasons of what people said. 7 in 10 Hispanic adults say they will get a COVID-19 vaccine, which is good, but it's interesting to watch these numbers change over time. There were still a number of people who were hesitant. Sorry, I think I went backwards. There we go. So this is back in November. 1 in 4 Hispanic adults say they'll get the vaccine as soon as possible, but 4 were saying wait and see. So each month when they do these surveys, they're not asking the same people. They're asking different people. This is a random sample, telephone call sample. So they're going to miss people who don't have phones, or they're going to miss people who don't answer the phone if they don't recognize the number. And of course, people might answer the phone and then decline to take the survey. So it's a little bit biased, but I feel like I'm seeing consistency every month about the number of people who were saying they want to wait and see. So what are they waiting to see? I can think of lots of reasons why people might want to wait and see. And some of it is just factual information, what I'm calling cognitive vaccine hesitancy. They don't know that 17 years of basic science research went on, or they don't know what was in the vaccine that doesn't contain mercury or some other materials. Or they're worried literally about cost. The vaccine is for free and there's no out-of-pocket costs, even if you have no insurance, but maybe we still haven't gotten that message to everybody. So lack of information, maybe it's lack of access, limited transportation, we need to make it easy. But I know that there are also rumors going on out there, rumors about that the vaccine is somehow going to change your DNA or decrease your fertility. But I think there's also some things about vaccine hesitancy that we could directly address. One of them is social norms. Do you know anyone who has been vaccinated? In the Kaiser Family Foundation, they asked that question in February, And they're asking questions about the people who had said that they want to get it as soon as possible versus wait and see versus not getting it. And they found that people who knew someone who had been vaccinated, especially if it was someone in the household or a close friend or family that was vaccinated, were much more likely to say that they wanted to get it as soon as possible. So I feel like one message we could give to people is talk to your friends and family. You may not realize it, but you probably do know someone who has been vaccinated. Ask them, what was their experience? Ask them why. Why did they get vaccinated? That might help to nudge that vaccine hesitancy. But a big part of it, we know, is mistrust. It's fear. Mistrust of government, of big pharma, the vaccine companies, medical mistrust. I think most people trust their personal physician or healthcare provider, but they don't trust the system. There are plenty of reasons for that. There's not only historical, but present day mistreatment of people of color by all of these systems. I know for immigrants, undocumented individuals, there's also fear of deportation, fear of the unknown about what's going to happen. But I do want to make a point that there's active and passive decision-making. To go and make an appointment, that's an active decision. And that's scary for a lot of people. They don't want to commit. But to just stay home and not get a vaccine is a decision also. It's a passive decision that you're willing to take the risk of being exposed to COVID-19. And then there's the question of who can you trust? This was the January wait and see who were, expressing concerns. They had lots of questions, long-term effects, side effects. They're not as safe as they're said to be. They're not as effective as they said to be. Who can these people go to? Who is their trusted source of information? This was the February one. A lot of the same responses as in January. I just show this so that these, I feel like we as we in public health are not getting enough information out about these concerns, that fear that they might have to pay, difficulty with traveling to a vaccination site. I found this very interesting, that 1/4 of those who said that they want to wait and see said they would be more likely to get COVID-19 vaccine if only one dose was required. We don't want people to waste time shopping around. I mean, the best vaccine to get is the vaccine you can get the soonest. But as we get more and more doses of vaccine, people will have choice. And as we have more Janssen vaccine available, people will be able to choose that. So if that's the barrier for many people, that they're afraid of side effects that they've heard from the second dose of Pfizer and Moderna, Janssen may be a good choice for them. I mentioned who can you trust? The Kaiser Family Foundation poll also asked specifically different racial ethnic groups, who do you trust of these different entities? And here you can see for Hispanic adults age 50 and older, in every category, they were more trusting of these different sources of information. For younger Hispanic adults, trust was still high for their own doctor, for the CDC, for their health department, but it starts to go down when you start to look at different political entities, such as President Joe Biden and their state government officials. So that mistrust of government is certainly there. How can we address vaccine hesitancy? Well, finding out what are the trusted sources and directing people to those trusted sources. I already mentioned, suggest people talk to those who've chosen to be vaccinated about their experience, dispelling myths. There is no biological reason why any of these vaccines, which only have the gene for the spike protein, there is no biological reason why they should affect fertility. But I'm going to give you some data on that as well. Because I think we have to ask about concerns rather than just telling people, don't worry, it's safe. Find out what exactly were their concerns so that you can address those specifically, so that you can nudge the wait and see and counter the people who say, oh, I don't need it. I'm young. I don't need vaccine. If I get sick, it'll be a mild illness. Well, it's true. If you're younger, you're less likely to be hospitalized and die. However, in some people, they develop what's been nicknamed long COVID, where symptoms carry on for a long period of time, maybe even months. So I think that message of I'm young, I don't need the vaccine, I think there is an answer to that, that it's not just about mild illness, it's also about long-term effects of illness. What about, I've already had COVID, so why do I need to get vaccinated? In fact, we do recommend that people get vaccinated, even if they've already had COVID, because you get higher antibody levels with the vaccine than you get with the actual infection. They have created these vaccines to really give a powerful immune response. And this is just something I copied from a tweet saying, you know, from an individual who's saying, this is, you know, anecdotal, this is just my story, but many long COVID survivors feel better after they get their vaccine, including me. And so I think that there is a good explanation of if you've got long COVID, that your body is still struggling. You get vaccine, you get an extra boost to your immune system. What about those specific concerns about lactation, fertility, and pregnancy? Well, I already mentioned fertility, but lactation, breastfeeding, is it safe to get vaccinated during if you're breastfeeding? It's not only safe, it's helpful for your child, because studies have shown that there are antibodies, IgG and IgA, in breast milk as soon as 7 days after the first dose of a 2-dose vaccine. So that's passive antibodies. You're actually providing antibodies to the nursing infant to help protect them during those critical few months of life. What about pregnancy? Well, I used to show this slide. Pregnant women weren't studied in the phase 3 trials. We don't have any biological reason to be worried. You know, the vaccines that are unsafe in pregnancy are the ones that have a live virus in them. There's no live virus in this vaccine. The theoretical risk is very low, whereas the risk in COVID-19 disease, COVID-19 is a bad disease in pregnancy. And furthermore, several different societies, American College of OBGYN, Society for Fetal and Maternal Medicine, they have all recommended that pregnant women be offered SARS-CoV-2. Well, oh, sorry, I do want to, hang on. Oh no, did I not copy those slides in here? I'm sorry, I'll have to copy it and send it to you later because I have additional information. I have a whole series of slides I just made around pregnancy. Remember I mentioned 100 million people have been vaccinated in the United States? When you are vaccinated, CDC gives you an opportunity to sign up to get a message on your cell phone. It's a system called V-Safe. And they send you a message every day for the first week and then weekly for the next 8 weeks asking, are you having any symptoms? Are you having any of the following? And they ask some specific questions. They also ask in the very beginning when you get vaccinated, if you're pregnant, would you like to sign up for this special system where they're going to ask you questions? So thus far, 30,000 women who are pregnant and got vaccinated have signed up for this system. And they have been able to look at those. Of those, they've studied about 1,800 of them, and about 300 of them have already delivered their babies. There have been no differences in the vaccinated women in terms of problems in pregnancy, like bleeding or premature delivery or preeclampsia, and there have been no adverse effects in their babies as well. So we do have data. We have good data about safety and pregnancy, and I will send you those slides after this presentation. So how many Hispanic Latinos have been vaccinated in South Carolina? A little more than 12,000 have had at least 1 dose. And this map is on our DHEC vaccination dashboard. The darker colors show larger numbers of people Hispanic Latinos who have been vaccinated in South Carolina based on the zip code of where they live. That's still disproportionate. You know, that's lower than we would expect compared to the number of Hispanic Latinos there are in the state. But of course, maybe some people don't report their ethnicity, or it may be real that we have more vaccine hesitancy and or other reasons why people have not been vaccinated. I want to show a very different map that is confusing, but go back to this one. Think in your mind, where is that I-95 corridor? Where is that? On this map, it's showing up in red. This map combines information from 2 sources. One is the social vulnerability index. Sorry, that's misspelled on this slide. That the social vulnerability index is something created by CDC. It takes into account 15 different measures that make you more vulnerable. So that is things like poverty, transportation. Do you have a vehicle? Do you live in a crowded home? Education level. Is there no one in your family who speaks English well? Takes all of those factors into account. So by zip code, people with areas with high social vulnerability index are in red or in orange. The blue have low SVI. Now, what about those circles? The circles show the COVID case rate. That's the number of cases per 100,000 people. So the larger circles show those rates. And then the darker circle in the middle, the dark red circle in the middle, that shows mortality rate, meaning the number of people who have died of COVID-19 per 100,000. The SVI and those mortality rates go hand in hand. I mean, that I-95 corridor, some of those areas with high SVI have really high mortality rates. You know, if you look at the Charleston area or Hilton Head area, yeah, they had a lot of cases, but they don't have a lot of deaths. Whereas that I-95 corridor, where we're not getting very many people vaccinated among Hispanic Latinos, has higher case rate mortality. We also know that there are workplace risks, and I had mentioned, some efforts to go out and vaccinate at specific work sites where we know that they cannot distance. We do have a number of materials that are in Spanish. I'm just going to quickly go through a few of these. These are on our website. General information, PSAs, outreach materials, FAQs. We have some myths and realities. And we do have some information that is not in Spanish, but is in Mayan languages. We're trying to create more PSAs and have more different faces to go out there because people are going to relate to people who look like them. I do want to point out that it is possible if you wanted to sponsor a vaccination location, because people are going to be more interested in going to a trusted community event, a trusted community organization, a church, different venues that are familiar to them rather than signing up to go to the big hospital or going to a pharmacy. You don't have to be an enrolled vaccine provider, meaning you don't have to have doctors and nurses and be able to handle vaccine. You can go to our DHEC website, click up at the top where it says want to offer a vaccination location. You click on that, it will bring you to the 6-question form. You fill that out and submit it, and then we can coordinate with bringing vaccine to your event. I want to mention one last thing about masks. CDC has some new recommendations around fully vaccinated people. And when I say fully vaccinated, I mean 2 weeks after your second dose of vaccine or 2 weeks after your single dose of the Janssen vaccine. Some people feel, what's the use? I get vaccinated, I still have to wear a mask, why bother? This is one of the reasons why bother. If you are fully vaccinated, the recommendation now is that you can visit with other fully vaccinated people indoors without wearing a mask and without physically distancing. You can also visit with unvaccinated people from a single household who are at low risk for severe COVID-19 disease. That means, in a nutshell, grandparents can visit with their grandkids. Because the grandkids aren't vaccinated, but they're at really low risk of having severe disease. So if vaccinated grandparents can visit with their grandkids. The other thing is that you don't need to quarantine and test yourself if you're exposed to SARS-CoV-2 if you have no symptoms. This is just a nice little visual image. This is from the CDC website, trying to show at the top, 2 households, everybody's vaccinated, you can get together. Or one household, everybody's vaccinated, and the other household, unvaccinated, but at low risk, no medical conditions, younger age, you can get together. Down at the bottom, there are some exceptions. You're fully vaccinated, but that other household has someone who's high risk, maybe somebody who has diabetes, heart disease, then we still need to stick to those prevention methods. But who is low risk? Certainly under age 20 is low risk and no chronic medical conditions. But I also want to point out obesity is considered a risk for severe disease. And sometimes people don't realize that they would fit that definition. They think, oh, I'm big boned. I mean, this is, all my people are big. The specific definition, and you can go, there's a website, you can get calculations, you can type in your height and your weight. But for example, someone who's 5 feet tall and weighs 153 pounds, that's a BMI of 30 or higher. That's at increased risk. 5'6" and weighs 186 pounds, that's increased risk. 6 feet tall, 221 pounds or more, that's increased risk. So there are still precautions for fully vaccinated people. For the sake of time, I won't read this. It's all on the CDC website. And we mentioned that you can organize a vaccine location. So with these new variants spreading, we're worried about more cases and more deaths, but as people get more and more vaccine into arms, I think these cautions will start to decrease. I want to finish on a positive note. Vaccines work, but masks also work while people are waiting for a vaccine. And the best masks to use are 2 or more layers. And ideally, they have 2 layers with a pocket in the middle to help filter those droplets. Do masks really work? I'm going to finish with just one story. And this is a story of 2 hairstylists who had COVID-19, but it was before they had symptoms. So they didn't know it. They were contagious, but they didn't know that they were. They were wearing masks and they worked with 139 clients. They insisted that their clients all wore masks. Now, you know that they were within 6 feet. They're hairstylists. They're right there working with people. You know that they are talking, and you know that they're probably spending more than 15 minutes with those people, but they all wore face coverings. When they developed symptoms, when those hairstylists developed symptoms, they got tested, found they were positive. They recontacted all those clients. Clients got tested. Not a single case of transmission. Masks do work.